stress in this slide is two things. One, if you look at the bottom, you see that as the bubbles representing the size of mortality risk from colorectal cancer, the current rates by race and ethnicity. And on the right, you see a map. The red, of course, shows something that is bad. And you see that the red areas cluster around Alaska and the Appalachian and Mississippi River Delta areas has been areas of concentrated higher risk of mortality from colorectal cancer. So it's a thing of race, but also of geography that's really important. And for many of you, of course, you look at it and say, duh, I know this already, because if you look at Appalachia, there are no colonoscopy facilities and people don't get access to screening. But screening it works. We know that already. There are many tests that are recommended. And so over the last 3 to 4 decades, maybe 3 decades, we believe the access to screening has made it possible to see declines. Clearly, lifestyle, the food you eat in your stomach and what you do with your body tend to define the risk of not just colorectal cancer, but also many other chronic conditions that our community experiences at the time. But talking about a test that I recommend that is very familiar list, and sometimes I break this down differently. But I put colonoscopy last because all of the tests that are performed, which tend to be more accessible, especially the fecal-based tests, because you can send them to people at home. They don't have to come to the office. But then if they do it and it's positive, they need a colonoscopy for that testing process to be complete, and we'll come back to it. There are some newer tests that are coming on stream online. Cologuard is coming with a newer test that is more specific and hopefully enhance cancer detection and reduce false positive rates. We all know about the FIT RNA test, which is almost like Cologuard, and the blood-based test Shield that got approved recently that is still making its way through the guidelines. Let's see if it gets included in the guidelines. In some way, this is an old slide when we were sort of all of us, in a colon cancer roundtable were clamoring to change the paradigm in which when you do a test to screen for colorectal cancer, like a fecal test, Imocult or FET, the colonoscopy that followed was a diagnostic exam and therefore attracted a co-payment. So we all know in this group very well that that paradigm has changed. And the new paradigm is that colonoscopy, based on Medicare's rules from 2023, is now a screening colonoscopy, or if it's easier, follow-up colonoscopy. That's the reason why we titled the talk the way it is. I think the key here is that the new paradigm is that it's no longer diagnostic, but when you do it, it is considered part of the screening continuum. So let's talk about complete screening. And we've all known this for a long time, that screening is not a single step, but it's a process. And so for us to get to a complete screening or completion of screening is that you have to get a test. And that is important, because if you don't get a test, none of the other things downstream will happen. But if it's negative, you have to keep rescreening, because the risk doesn't go away unless some unfortunate thing happens and you lose your colon, in which case your risk then is gone away. But we hope that doesn't happen. But as long as you have a colon, your risk doesn't go away. And the risk actually increases as you age. And so it becomes even more important for you to keep screening over time. And so when it's negative, you get to rescreen, and that's the loop. But the key here is that for complete colorectal cancer screening, it includes a follow-on screening colonoscopy after a non-invasive screening test returns a positive result. So that's a CMS language. We hope it stays, because I think this is life-saving in my view. And the U.S. Preventive Services Task Force, while I was on it, when the new guidelines from 2021, we added this language that we believe serves as a catalyst. It took a village to get there, but this was the language that was added. So what's a complete colon cancer screening? It basically means people at average risk, a non-invasive test is done, you do a full-on colonoscopy when the test is positive. That's one. If it's negative, it's good. If it's positive, you got to have the full-on colonoscopy before it's considered complete. However, if you get a colonoscopy done and it's negative, you have a complete screening test, right? That is one. So it's one step versus two step. You know, the aspiration for me and many others in this area has been that your colonoscopy itself is not always equal to each other. So you have to have a good quality colonoscopy, and if you don't have a good quality colonoscopy, our studies and others have shown that that actually doesn't sufficiently lower your risk. You can get missed colon cancers that can cause death. You can also have missed adenomas that can then result in earlier onset post-colonoscopy cancers that also can result in preventable death. So this is all important stuff. So what about the rates of follow-up colonoscopy? And this varies. And the trouble here is that we're beginning to pay more attention to this recently. So there are some new studies I'll talk about in a minute that are demonstrating the rates of follow-up, which is unfortunately lower than we want to. In some areas, you see that the rates are much lower than desired. So this is a study we did back in 2000. This was published in 2016 or so, even earlier. I don't have the date here, but this was looking at the Prosper Network. We looked at the health systems. Parkland UT Southwestern is a safety net system. And not surprisingly, the follow-up rate is lower. So the lower means it's not as good. And then in between is group health at that time. Group health has since become Kaiser Permanente in Washington. And the top ones that you see are Northern and Southern California. So the patterns of those two systems are all too familiar to me rather, because I work with them and see those patterns fairly clearly. All right. So let's get to the meat of our conversation today. So why is it important? And the key here is that when you are positive for screening, a stool-based screening, it does mean that you could have cancer, because patients will ask the question, you know, if it's positive, can I just repeat it? The answer is no. If you repeat it and it's negative, it doesn't mean that the positive is not important. And so repeating a test and getting a negative test doesn't take away the need to still do the colonoscopy. So the answer to a fecal test is positive. Any test that's positive is not to repeat and prove that it's negative, because bowel bleeding can occur intermittently. And so a negative test doesn't rule it out. This is a modeling study, and modeling studies are both nice and sometimes confusing, but this I think is important. One of our earlier studies in this area, and this was indeed 2016, done by our colleagues from Erasmus Medical Center in the Netherlands using a Miskin model. As you can see, there's this slope that goes up, right? So by every month of delay, according to this estimate, you get a 0.1 increase in the incidence and the same rates for mortality. So the way I use this graph is to say that the sooner you get a follow-up colonoscopy, the better. And we'll come to some of the latest studies we've done and some of the discussion around how soon is soon and good enough. And I don't know the answers there. In my view, the sooner the better, knowing that resources can limit that aspiration somewhat. In Kaiser Permanente, they're going for 6 months, 80% by 6 months, which is great. Anyway, the longer you delay, the higher your risk. So please keep a mental picture of this graph, this sort of steady slope over time. And so let's come to a couple of studies that we have done here. And so this is a nested case control study, as I shared earlier. I've done a lot of work with Kaiser Permanente systems, particularly in Northern and Southern California. In this study, we looked at 1,750 people who had died from colon cancer. It's not just cancer, but colon cancer, and people who did not have a history of cancer that were matched to them. And we asked the question, what if there was a failure in the process of screening? What if they didn't screen? And more importantly, what if they didn't follow up? This is also a good way mentally, in my view, to walk through the screening process, right? A group of people will not screen at all. And that's, you know, about 30% nationally in most systems, perhaps 20% people will not screen at all. And some start screening and they don't continue. Others get a negative test and they don't continue. And some get a positive test and then they go back to have the colonoscopy done and that's all good. And for some people, they don't get the follow-up colonoscopy. And again, we'll come to those rates in just a minute. So what is the risk of any of these steps in terms of dying from colorectal cancer? So these are the proportions. So you can sort of eyeball it and see that in one of these groups, 8.1, right? The lack of follow-up, right? The 8.1 versus 1.2, that's a huge difference between these two. The comparison group is the lowest group, which is the 44.6 and 24.1. And if you look forward a little bit, you see that indeed for that group who did not have follow-up colonoscopy, their risk of dying from colorectal cancer was at least sevenfold higher, right? That is huge. So people who don't get follow-up after a positive test, abnormal test, have a very high risk of incidence and mortality from colorectal cancer. So to me, this is an important reason to think about a screening as a process, and failure at any of these steps can lead to increased risk of mortality. And but also, I think helps to create more value for our efforts, right? To get people to the point of getting screened. And when they get screened, you want to make sure that they go on to get a colonoscopy because that is the only path through which the benefits can accrue. All right, so we did a follow-on study. They published in different sequences. This was published in JAMA. And in this study, we used a cohort approach and saying that what is the time to colonoscopy, and then what is that risk of any colon cancer, the mid-stage or stage 2 colon cancers and the advanced colon cancers. So a large group of people, 70,000 plus patients in Kaiser who had positive fecal immunochemical tests. You can see the median age there, a moderate number of cancer cases were detected within this group, and 601 of these were in advanced stage. And you can see from this that compared to people who got their full-on colonoscopy between 8 to 30 days, we ignore the first 1 week because that period is kind of difficult to tell whether they actually tests were done as diagnostic, and so we ignore that first 7 days, and because there's some confounding by indication there. And you see that by 10 months, there is a very strong association. So these numbers you see here for 10 to 12 month period. And within that period, a 1.5-fold higher risk of any colon cancer. Stage 2 is 2.4, and stage 4 is 2.7. In other words, if you delayed your full-on colonoscopy by 10 to 12 months, you have a 2.7-fold higher risk of getting an advanced colon cancer diagnosis, which of course has not as good a prognosis than the earlier stage cancers. So I think the combination of these studies led up to a series of guidelines that then create some threshold around this. And of course, as many of us are involved in the process, trying to persuade some or make some change in ensuring that we have a way to monitor the follow-on care after people get screened for colorectal cancer, for any condition, for that matter, whatever you get tested for, if it's abnormal, then you don't just sit on it, and it could become a time bomb. So this is a modeling study that was actually done by Exact Sciences. I participated in this study. And in this study, it was sort of hypothetical, but it's realistically hypothetical in my view. And basically the question was asked, put the two together, because I think when you put the two things together, as I've said before, the quality versus a follow-up colonoscopy, and you're looking at a potential gap between Black people and white folks in terms of the adenoma detection rate and full-on colonoscopy, and you assume that the differences are 15 or 10% apart for those two measures, then this is what you see. The base assumption here, and based on a study that was using the Optum database, it found that only 56% of people, right? You saw those graphs before, you see the differences within the health system, but in this study, only 56% of people went on to have colonoscopy after an abnormal FIT. So that's a low number. Screening rates are not ideal. That itself is a low number. And so if you achieve that, if you corrected that difference by race, this is the benefit you can get, 18.7% in terms of mortality and life year gain of 7.1%. So it will make a difference to ensure that we provide follow-up after abnormal tests. So the question naturally is that as all of us have done this work, what can we do? And so I'll tell you my own piece about this. There's some research that shows the things that we can do to improve it, and typical things about patient navigation, reminder systems, provide performance data, and, automated referral, like in the Kaiser system. They do that. Once the test is positive, it gets routed to GI, and they track it until it's taken care of. Patient registries are important. We don't have those very well. EHR systems, if you have one, having registries will help. I wish, my dream, another dream here, is that I wish we had the registries like immunization registries, right? So if you pop in and drop in your screening events into your EHR wherever you are. And so there's moderate evidence here that patient navigation and provider reminders to work. But I can't imagine why automated systems couldn't work, because in the more practical environment of Kaiser, that's one of the key things that actually works. So having some process to do that definitely makes a big difference. So I put this here because having said all of that, life happens to all of us and our patients. And this concept of accessibility is important, right? So, and to me, the one big thing, my pet peeve on all of this is availability. So if you're in a rural, remote area, Mississippi Delta or somewhere in Louisiana, where you have a colonoscopy desert and you have a test that's positive, where do you go? How do you get there? And that's a challenge that our patients face, right? And that's a challenge for us to solve for. I have been sort of bold enough to say maybe you shouldn't actually start screening until you have a process for how you get people to the colonoscopy, because if you can't do that, why do the test? But I think having resources within the environment in which people can access is really important. Transportation is important. Uh, you know, making sure you understand people's values are important, and preaching to the choir here, and then the hours of operation and other things, and making sure the community is informed, addressing costs. And cost is not just out of pocket, but time out of work to go do the prep. If you have to travel, then the time it takes to travel, so it's a lot there. So this is what I feel as some of my big takeaways on this. To really make this work, everything needs resources. But to make this work, you need commitment, you need accountability. You need to have measures that are there for people to track, because right now there are no clinical measures. And so we track our screening rate and we say, this is great. But then we don't look to see that people are not actually following through on their abnormal screening. So that's really important. And to make sure that we have the capacity, as I shared earlier, to provide the colonoscopy when people are positive, we are actually trying to advocate now to ensure that uh, we try to prioritize, right, full-on colonoscopy over routine screening colonoscopy, right? Because if all the capacity is used just to do routine screening, we don't really have the capacity to do full-on colonoscopy. So what if we flip that a little bit and say if someone is got a positive stool-based test, and I think Penn shared with me that they're doing that, they actually save some slots in their schedule, that when someone is positive, they just slot the person in there. But a month or so, if there's nobody's taking the slot, then they flip it and provide it for routine screening. So those are sort of simple administrative things that we can do. So again, speaking to a really informed audience here, but I'll share some thoughts. Really patient education and awareness. And so when someone is getting screened with fecal tests, I love it. We can send it to you at home. But please understand that if it's positive, we need to do a colonoscopy. And so I think having that patient understand that approach as the complete form of screening is really important. We need to understand patient barriers. What do I mean by this? It's amazing what you find when you ask people, right? If they have a positive test, can we just ask, do you have transportation? Do you have food insecurity issues? Do you have housing? Do you actually have a stable home? Are you in a sort of a shelter situation? I think those are really important. I shared with you that with the AGA, American Gastroenterological Association, we're trying to do some work we have a paper in press advocating for prioritizing full-on colonoscopy versus routine screening. I know there's a big pushback from the GI community, understandably for business reasons, but again, improving resource availability is important. Measures and tracking of follow-up rates is key. Provide tailored navigation. Colonoscopy is not difficult test, but it's difficult for some people, and navigating may not be easy. The prep and all that. I think it's really important for patients who need it to provide that support and navigation. We have to be able to provide the transportation because you go to sleep or get sedated, and then you need someone to get you home, without which they won't do it. And so there are, I think, really creative ways we've been addressing this recently to ensure that maybe Uber or Lyft Right program to get people back home. It talks about prioritizing follow-up colonoscopy. Community engagement is important. But really, we have to create a measure, right, to support this. Hopefully, NCQA will endorse a measure to support this so we can begin to track this nationally to understand where the gaps are. Because I do worry in some areas you get like a 0 follow-up rate. We're doing a study with Vanderbilt, and the rates are not great, but at least it's not 0. That made me a little bit happy, but not happy enough. And then data systems to track this, even if the registry is important, and we have to incentivize this. So again, thank you so much for the opportunity to share with you. This is a topic that I am super excited about. And I know that, we all face this challenge of getting the right thing done. Getting people screened is the first step. Getting them to full-on colonoscopy is really essential for the test to work. What I've shared with you hopefully demonstrates that you have evidence to take back with you to your community and say, hey, if we do this test and it's positive, we have to get them to the colonoscopy, otherwise this is all for naught. And so that's what I wanted to share with you, and thank you for the opportunity.
Yeah, thank you so much, Dr. Dalbany. It's great presentation, a lot of information in it that hopefully will be really helpful for the coalitions and the people who work with coalitions that are on the call as well. Um, we did get a couple questions in the chat, so
Okay.
I'll kick it off with one that I think you started to address, but perhaps you have some really clear advice for this person. And it says, in New Mexico, we have a shortage of providers to provide colonoscopies. You touched on this talking about
Mm.
Louisiana, for example.
Mm.
What can we do in these cases?
Geez, you can tell I'm sort of starting back, just rubbing my eyes. New Mexico, Mississippi, I mean, the list goes on. If
Mhm.
you're in states even like ours, where you have a vast rural area, you have the colonoscopy facilities kind of located. And even in our system, we have people who perform them, but the appointment slots are really so hard to get, right? Um, I think the piece here is to sometimes actually we discover that people don't accept some insurance. They won't take Medicaid. Hopefully that is changing. And so if that's the instance, I think advocating for changes to insurance coverage, as people, I think San Diego or California C4 was successful in doing some of that. It's an
Mhm.
essential piece. I think South Carolina did something similar. It's an essential thing. We in our system, my office is provider supports, on and off, and it's not good enough for free colonoscopy clinics. If you're really desperate, that's one approach. If you get volunteers to go out to the community or to areas in which you can get people who are positive to get the full-on colonoscopy. The commonest reason, in my view, all right, besides the deserts where there's nothing, the commonest reason is that the system is choked with these routine screening colonoscopies,
Mhm.
right? So there's really no space there to squeeze in someone with the full-on colonoscopy. So I would say identify the area. New Mexico and Albuquerque and other areas will have colonoscopies, not enough, right? And there is vast states, right? It's long driving distances. but it may require providing transportation to get people there. And my only other suggestion is that if you're going to go through that step, just make sure that they are well prepped, because
Yes.
there's nothing like going through all of that and discover that the bowel prep was poor.
Yes. And just a little insider knowledge for you all on the call as well. The ACS NCCRT is developing a resource around rural colorectal cancer screening. So more to come on that in the coming months, but hopefully that will help to alleviate some of these questions about kind of these spaces where it's very hard to find colonoscopy and access to that full screening continuum. We have another question that is not surprising because it's a very hot topic.
Mhm.
And I think this might be our last question because we have to go to breakouts. But what are your thoughts on the new blood test as a
Mhm.
standalone screening or any version in the screening continuum?
Yeah, this is a very important question. So currently, and this is my point of view and the point of view of many people in my circles, that the blood test is not the primary test that should be used for screening for a number of reasons. One, it is not very good at detecting the precancerous adenomas or precancerous lesions. So for fecal tests, Cologuard and others, you pick up a fair number of adenomas that also help to prevent colon cancer. I don't expect that these blood tests are going to be able to do that until the technology improves. But certainly, I would not use a blood test to verify if a test that was positive is a true positive. So I wouldn't do the blood test as a way to prove what the initial test result was. Just as I shared before, if a test is positive, you really got to get a colonoscopy done. And getting a negative test, either blood or another stool test, doesn't prove that the first test was false positive.
Yeah. Yeah, I think all of the data that you showed just shows how important it is to get that follow-up colonoscopy after any sort of stool-based test.
Mhm.
It's just and blood tests are, like you said, a whole extra can of worms that will
Important, but we don't know.
yeah.
I think they're here, and we have to deal with it. But they're an adjunct, but they shouldn't, in my view, replace current screening tests yet.
Yes, yeah. And I'm sure there's going to be more to come as the tests develop more and so on. But thank you so much, Dr. Dalbany. It's been such a pleasure to listen to your presentation. And we're going to move on to breakouts because there's so much information and almost not enough time to talk about all of it. But